Good afternoon, good evening, good morning from wherever you are joining. Welcome to the Zoom academic meeting of the Department of Paediatric Surgery on Tuesday, 13th of May, 2025. And we have Dr. Martin Douglas Jones, who is going to talk to us about intra-oral and maxillofacial pathologies. What do pediatric surgeons need to know? So Dr. Douglas Jones is he is a maxillofacial and oral surgeon at Krutoskir and Red Cross War Memorial Children's Hospital in Cape Town. He did his undergraduate dental degree at the University of Stellenbosch. He did his medical degree at the Wits University in Johannesburg. He did his registrar training at University of Western Cape in Cape Town and an AO fellowship in Basel, Switzerland. He has worked in the Eastern Cape as a medical officer and as a maxillofacial and oral surgeon consultant. He graduated from the surgical leadership program, Harvard University class of 2022-2023. And I know Martin is a very family man and he is friend with many of us in East London. We miss him here, but we understand and we support his career choices. So Martin, I will stop sharing. You can share your screen and you can start your talk. Thank you.
Thank you very much, Prof. Chitnis. It's always nice to chat to you, and thank you for a very kind introduction. I sort of appreciate that. As you mentioned, I've got a very soft spot for the Eastern Cape, and it's great to be with you today. So, um, sort of in preparation for this talk, I didn't really want it to come across as sort of punting maxillofacial surgery, but it may come across that way. And I sort of the hope is that this talk will be quite informal. And if you do want to stop me as we're going along, please do. Um, yeah. So the thought is I just want to give you sort of a brief idea of maxillofacial surgery, and then we can sort of unpack it as we sort of move along. So the title I try to be clever and sort of get uh, a few T's together here. So teeth trauma and tiny face pathology, maxillofacial surgery for the pediatric surgeon. So just briefly, a sort of a roadmap to this presentation. I'm just going to give you sort of an introduction to maxillofacial and oral surgery. I think it is a really small speciality and often sort of not really well understood. I'm also going to sort of look at some key aspects of maxillofacial and oral surgery, and I'm going to add dentistry to that as well, because I think often sort of within sort of medical training, I know when I was at med school, there was almost sort of no dental training in the undergraduate medical program. I'm hoping that we're going to be able to sort of put everything together and see how maxillofacial surgery fits into the hospital and definitely into pediatric surgery, and then sort of briefly deal with maxillofacial and oral pathologies. And I think one of the things to bear in mind is that any one of these pathologies could sort of have a lecture on its own, and we're going to try and just keep it quite informal and very superficial. But I'm willing and happy to take questions as we go along. So the objective of this talk will be to highlight the relevance of maxillofacial and oral surgery in pediatric surgical practice, and then hopefully for everyone to understand maxillofacial pathology and maxillofacial surgery scope a little bit better, and then sort of putting it all together is that sort of to try and highlight the importance of interdisciplinary sort of understanding and multidisciplinary teams in patient management. So what is maxillofacial surgery? And I think often sort of when sort of we think of maxillofacial surgery, we sort of see this picture on the right-hand side of the screen. We sort of think of sort of wisdom teeth, and I think that's sort of generally sort of the perception sort of out in the public and possibly sort of within the sort of medical fraternity as well. But generally, it's sort of the best way to explain it would be that it's a surgical specialty focusing on sort of the mouth and teeth, the jaws, the face and the neck, and sort of putting together sort of pathology of both the hard and the soft tissues in this region. So we often sort of joke and say that we sort of the orthopedic surgeons of the face, plates and screws that we would use quite often sort of in a lot of the procedures we perform. This is the Tsitsikamma Bridge. So it's the bridge between sort of often if I'm sort of heading down to East London from Cape Town, I cross this bridge. But I think sort of maxillofacial surgery is sort of the bridge between medicine and dentistry. And yeah, I think sort of it's a good sort of way of describing maxillofacial surgery. So key aspects of maxillofacial surgery would be dental-alveolar surgery, which would include things like surgical removal of teeth, dental implants. Obviously, sort of dental implants in the pediatric population would be very limited. Maxillofacial trauma, TMJ. TMJ is sort of very sort of different within sort of the adult and the pediatric population. Facial pain, we don't often deal with facial pain in the pediatric population, but it is most certainly present. And what we're finding is more and more sort of that it is becoming an issue, particularly within sort of adolescence. Then sort of looking at sort of maxillofacial pathology, and these would include obviously sort of benign and malignant pathologies of both the bone and the soft tissue, as well as the salivary glands. I'm going to deal briefly with orthognathic surgery and then sort of craniofacial and cleft pathologies. Generally, sort of maxillofacial surgery sort of operates sort of in interdisciplinary teams, and sort of from the dental side, we often work with the dentists, which I sort of omitted from this. I apologize to the dentists here, but sort of working closely with the dentists, we work quite closely with prosthodontists, which are sort of people who build prostheses for the mouth. So often sort of dentures or sort of implant retained prostheses to help with function. They also sort of help and often do things like crowns and veneers and do quite a lot of aesthetic work. Then there's periodontics and oral medicine, and they often sort of are involved with sort of the structures that support the teeth, so the bone and the ligaments that hold the teeth in the mouth, and then sort of the oral medicine side would be sort of the systemic sort of involvement of the oral environment in systemic disease. Orthodontics is something that I think most of us sort of are aware of, and that would be sort of dealing with sort of the misalignment and malalignment of teeth and sort of putting on braces and straightening the teeth and sort of getting a good smile. There are maxillofacial and oral surgical pathologists who are quite similar to anatomical pathologists, but their sole sort of focus is obviously sort of head and neck. Pediatric dentistry, we work closely with them. I've put them in brackets because they aren't actually a sort of a speciality at this point, but they are sort of striving to become one and are in the process of getting that ball rolling. And then we sort of work with other allied health sort of professionals within sort of the dental realm, and that would be sort of the oral hygienists generally. Sort of on the medical front, we sort of generally work quite closely with the plastic and reconstructive surgeons. Here in the Western Cape, we actually share the trauma call roster with the plastic and reconstructive surgeons. We work quite closely with neurosurgery and ENT and ophthalmology, and that would sort of make sense just because we sort of in that sort of area. We sort of all sort of standing on each other's toes. We work quite closely with the pediatric surgeons down here, obviously with medical genetics, particularly in the pediatric population, and then sort of with the allied health professionals. So things like the audiologists, the speech therapists, the dietitians. So interface areas where we sort of work with the pediatric surgeons, and I think sort of we all have sort of this ideal sort of outlook to the patient, where we're sort of looking at the biopsychosocial model, and we're trying to sort of give the patient the most comprehensive care. I think sort of we obviously sort of need to be looking for, from a maxillofacial point of view, pediatric surgical conditions, and from a pediatric surgical point of view, looking for maxillofacial surgical conditions. I think sort of what we're finding is that the pediatric surgical discipline is obviously sort of the first to sort of identify maxillofacial and oral surgical pathology and refer on. And sort of, I think we're all looking for the best patient's outcomes and to work in sort of multidisciplinary teams where we can all learn off each other. So sort of key considerations from a dental perspective, and I'm just going to go through these quickly because I'm going to try and sort of make it a little bit more interesting with pictures and describe them with pictures. But I think sort of it's important to know sort of normal tooth development, as well as stages and the normal oral anatomy. I think sort of tooth decay and is something that you would see on a daily basis. Periodontal disease, crowding, which is sort of malaligned and misalignment of teeth, oral habits, dental trauma, the dental health impact on general health, and I think sort of more and more this is becoming sort of coming to the fore sort of in literature where sort of these chronic sort of inflammatory conditions have been shown to be associated with Alzheimer's and cardiac disease and the rest, and then sort of oral presentations of systemic disease. So sort of looking sort of at normal tooth development, I think sort of it can be very complex. So if you look at that sort of diagram, it can be very complex where it says it erupts in a certain amount of time and the rest. But I think sort of particularly with the primary dentition, the rule of fours generally helps. And that is that from 6 months, every 4 months following the first 6 months of life, there will be an eruption of a sort of symmetrically eruption of teeth. And that would most certainly help sort of with sort of knowing when the normal development happens. Generally, sort of the mandibular teeth erupt first, and generally sort of it is quite a symmetrical sort of process. I'm going to sort of just chat briefly about natal and neonatal teeth. So natal teeth sort of are teeth that are present at birth, and neonatal teeth are teeth that sort of erupt within the first 30 days of life. I think sort of the concern with these teeth is often that they can affect sort of feeding. They can be mobile and hence be an aspiration risk. And they can traumatize the tongue. So if you have a look at that sort of diagram on the lower right, there's a condition known Riga feeder. I had to write it down because I always forget it. Disease where these teeth actually sort of traumatize the tongue and obviously then sort of can sort of influence feeding and lead to sort of issues with feeding. Generally, sort of the way to sort of approach it would be to sort of round off, get one of the dental colleagues to sort of smoothen off the teeth so they don't traumatize the tongue. But if that is unsuccessful, then sort of having to then sort of extracting these teeth is probably the next move. And I think just to bear in mind that if this needs to happen within the first few days of life, obviously sort of vitamin K is something just bear in mind. Then sort of I think sort of quite a hot topic and buzz at the moment is ankyloglossia. And I think sort of if you look sort of around the world, amongst sort of the pediatric surgeons, the maxillofacial surgeons, the dental fraternity, ENT, plastic surgery, there's definitely been a sort of a quite dramatic increase in the number of tongue tie releases that are being done. And the interesting thing is that probably 75% of patients who would fit a definition of tongue tie are asymptomatic. So I think just to bear in mind with regards to tongue ties is often sort of less is more, and less is most certainly a functional issue. And obviously sort of in the neonate and the pediatric population, that would be sort of function with feeding, and then sort of later on with articulation. Put this slide in because I think sort of often sort of pediatric surgeons would be the first sort of point of call for sort of identifying that there is dental decay. And if you have a look at that picture on the top left-hand side, that is sort of baby bottle caries. So essentially what happens here is that sort of very early on in the child's sort of life and development, they're sleeping with a bottle containing sort of either sort of milk or with sort of tea with sugars. And what it just does is just accelerates sort of dental caries. And this obviously then leads to things like dental abscesses, pain, discomfort, and obviously sort of affects function. Sort of that middle picture is sort of periodontitis, and that the thought behind that is that sort of often sort of with poor oral hygiene, sort of the gums become infected and can lead to bleeding and discomfort. Sorry, I was going to go back there. And then finally, sort of that last picture on the right-hand side, what I'm just trying to show there is sort of the primary teeth. So often there's sort of this sort of notion that sort of removing teeth and moving primary teeth isn't an issue. But I think there most certainly is an issue with removal of primary teeth, particularly the posterior sort of occlusion or teeth. And that's because what they do is they actually provide space for the permanent teeth to erupt into. And without them, sort of the teeth have this sort of natural inclination to drift forward in the mouth. So as soon as you lose a tooth, inevitably what happens is that the space that is there is sort of lost and sort of can lead to problems later on and sort of the need for orthodontic treatments and the rest. I brought this in. This is sort of a little bit of my own personal sort of a personal reason to bring this in. So I'd been giving my son fluoride as a child to try and prevent dental caries, and when his teeth sort of started developing similarly to this picture on the right hand side of the screen, I was concerned that I'd given him fluorosis of the teeth. But there's sort of become an understanding recently in the literature that a lot of these discolored and malformed teeth is a condition called molar incisor hypermineralization, where the enamel of the tooth is softened and often fractures away from the teeth and makes these teeth susceptible to dental caries. And then just the picture on the left-hand side is fluorosis of the teeth. And this can be often found in areas where sort of the water content it has a very high fluoride content. And in sort of initially what it can do is sort of create sort of white chalky patches on the teeth, but can actually sort of form these brown pits on the teeth as well, sort of in where the concentrations of fluoride are very, very high. Dental crowding and malocclusions. I think we often see this, we see patients on a day-to-day basis and we sort of don't sort of take notice of this. But I think, as you can see in this picture, there's most certainly sort of ectopic eruption of teeth here and malpositioned teeth. And I think one of the important things is if we pick this up early, and we send this on to either an orthodontist or onto a dentist, often sort of space can be maintained, created, and sort of more complex future treatments can be avoided. Okay. With regards to malocclusions, these can include things like sort of a deep bite, an underbite, an overbite, these overjets. And I think sort of, I don't think we need to sort of know how to manage them, but I think sort of it is important to be aware when we're seeing patients of these conditions and being able to sort of refer on. Dental habits, I think sort of again, it's something that we sort of don't give much thought to, but they can have quite significant sort of impact on sort of the oral environment. So if you have a look at this picture, sorry, these pictures aren't particularly clear, but if you have a look at this picture on the left-hand side, you can see that there's an anterior open bite. So you can see the posterior teeth are in occlusion, so they're sort of biting up against each other. But the front of the mouth is an open bite, and this has been caused by thumb sucking, where the front teeth have been splayed and created an open bite. And actually, if you look at this, you can see that the maxilla is becoming very constricted and is starting to develop a cross bite on the posterior sort of occlusion. So the posterior teeth are sort of in the wrong position now. And if you have a look at the picture on the right hand side of your screens, this is what we would call a tongue thrust. So what happens is that the swallowing habit happens where the tongue gets thrust between the teeth and then creates an anterior open bite. And again, sort of noticing this early allows one to get these patients to the dentist or to an orthodontist who can sort of address this and try and sort of mitigate the consequences of these habits. Just briefly dealing with dental trauma, if you have a look at that picture on the top left-hand side, dental trauma to the teeth often sort of involves sort of either fracturing of the enamel or the enamel and the dentine, or sort of fractures down into the nerve and the blood vessels of this teeth of the tooth. And if you look at that picture, you can see sort of the tooth is actually bleeding, and that's because the nerve is exposed. And again, I think sort of particularly in sort of patients presenting in trauma, often sort of in the secondary survey, often looking sort of in the mouth is neglected, and these sort of things are missed. If you have a look at sort of that picture in the center of the upper center of the screen, you'll notice that there's that central tooth that is discolored. It has a blue hue. And I think often sort of trauma often goes unnoticed. And later on, sort of in the child's development, sort of this discolored tooth is noted. And I think it's important to realize that when a tooth does discolor, it inevitably means that the tooth has lost its vitality. So the nerves and blood vessels feeding that tooth have died off and are susceptible to developing a dental abscess. So if you look at that picture on the top right-hand side, those are dental abscesses, often called a gum boil. And it's generally sort of those would be sort of relatively asymptomatic, but they can become sort of big and lead to other sort of bigger problems. When it comes to sort of treating dental trauma, the dentists often sort of splint teeth. So if you have a look at that lower left-hand picture, you can see those are what we would call an arch bar. And you can see that there's sort of fractures of those anterior teeth. So there's a fracture of the enamel and dentine and a bit of the enamel on the front left tooth incisor. And often these sort of splints are used where the tooth has either been avulsed, so sort of knocked out of the mouth and reimplanted into the mouth, or where the tooth has been traumatized and has become mobile. So in the primary dentition, often the thought is that in trying to keep the primary dentition, it often makes more sense just to extract the teeth. Because what can happen if you sort of reimplant primary teeth is that they can sort of damage the permanent sort of follicle or the permanent tooth that's developing underneath the tooth. But in the obviously sort of in the permanent dentition, the thought is to try and keep as to try and keep the teeth for as long as possible. And often sort of like I mentioned sort of earlier, is that often sort of teeth that have been traumatized can become non-vital. So they can lose their nerve and blood supply, and this can happen even years later. So it's just something just to bear in mind. And when you're talking to parents, often sort of just mention that to them. Key considerations from a maxillofacial and oral surgical perspective. So this is probably sort of, again, sort of where I would sort of fit in. And we're going to have a look at sort of infections of the maxillofacial region, tumors and cysts of the maxillofacial region, trauma. And here I'm not going to deal with dental trauma again. Congenital abnormalities, and this would include cleft lip and palate and a whole lot of craniofacial syndromes. And then sort of, we'll just have a briefly look at sort of functional issues and ways of sort of dealing with sort of some of the functional issues that can affect the pediatric population. So infections of the oral facial region, um, commonly odontogenic infections occur in children, and generally they sort of present pretty sort of inconspicuously, sort of so with sort of a gum boil. And if the gum boil's draining, often that isn't associated with any pain. So if you have to look at that picture on the top right-hand side, you can see next to that tooth, there is a gum boil draining. That posterior tooth, the most distal tooth is carious, and that's sort of leading to that infection. But dental abscesses can become sort of a lot more, and I'll show some pictures a little bit later on that. Often sort of teeth that are erupting, so sort of in sort of the adolescent, often when sort of either sort of what we call the second molars or third molars are erupting, there can be what we call a pericoronitis developing. So there's a little flap of skin that overlies the tooth that's erupting into the mouth. And should any sort of food particles or anything else get trapped underneath this tooth, it can lead to infection. So it can lead to pain, and that's often associated with pain. And because of the swelling of this sort of little flap of skin that is over the tooth, often the opposing teeth traumatize this and just sort of perpetuate sort of the pain and swelling associated with it. Diagnosing dental abscesses often sort of requires imaging. And if you have a look at this pan on the lower right hand side, you will see on these, I wish I had a pointer here, but if you look on those sort of molar teeth, you can see how they are carious. So they've got those dark areas, portion of the tooth. And if you have a look at the ends of their roots, you can see how there's sort of a radiolucency at the end of that root. And that sort of is what a dental abscess would look like on a pantomogram. As I've sort of alluded to earlier, sort of infections in this oral facial region can become a lot more serious than just the gum boil. And sort of red flags that would indicate this would be things like trismus, which would be sort of a decreased ability to open the mouth. And often what this sort of indicates is that there's sort of inflammation happening within the facial spaces that include the masticatory musculature. Dysphagia and dysphonia. So often what happens is as these infections track, they sort of move around sort of the pharynx and move down the pharynx into the neck. And as they do so, this sort of could lead to dysphagia and dysphonia. Often what happens is that as these potential spaces are, as infection is tracking along these potential spaces, often sort of drooling occurs. So because the floor of mouth being raised, it's difficult to swallow, so drooling can happen. Stridor is obviously sort of a serious airway concern. eye signs. Uh, Dental infection of sort of the maxilla can be associated with things like cavernous sinus thrombosis. So eye movements and blindness can result. It's important to sort of watch for that. And dental abscesses in the maxilla and mandible, in fact, have been associated with brain abscesses. So any sort of focal neurology and the rest sort of can, would be danger signs. I think also just to bear in mind is that sort of any infection of the face doesn't necessarily have to be odontogenic in origin. And I think very often we sort of see kids with caries being referred to us with odontogenic infection. But if you have a look at the sort of picture on the lower left-hand side, this child has actually got a complicated sinusitis that is there. And if you compare it to the child sort of next on in the line, you can see they do look very similar. So I think sort of obviously sort of identifying the causes is incredibly important. Um, the picture sort of on the second from the right is sort of the danger triangle, and those are sort of that's the area where cavernous sinus thrombosis infection in this area can lead to cavernous sinus thrombosis. And then sort of the picture on the far right would be a submandibular abscess, which is sort of tracking down into the neck. What we tell the dental students is always remove the cause. So we give them sort of a five-step process, which is identify the cause, remove the cause, incision and drainage and irrigation, MCNS, and antibiotics is the last point of call. And I think all too often antibiotics are prescribed way too early, are prescribed and the cause isn't actually removed. And what this leads to is sort of more severe odontogenic infections. I added this just today because this is sort of something that's come in just today. But this child is being worked up currently, and as you look here, you can notice sort of there's quite significant erythema bilaterally, sort of over the submental and submandibular areas. But the area of concern is that area of duskiness that you're seeing in the neck. And my concern with this child would be that there would be a necrotizing fasciitis developing here. And I think again, uh, um, there are quite serious concerns or quite serious consequences of not dealing with odontogenic infections. And necrotizing fasciitis and spreading infection even down into the mediastinum are sort of serious issues that are associated with odontogenic infection. Dealing with tumors and cysts of the facial region, I've put this picture of the World Health Organization's sort of booklet on this, and every few years they relook oral facial pathology. And as you can imagine, sort of there are numerous, and I think it would be impossible to do that subject justice tonight. But I think it is important just to realize that there are a lot of common benign lesions that are found in the mouth, and these would be things like odontomas. So an odontoma is a tumor that is actually sort of made up of malformed tooth structures. So it has dentine, cementum, and enamel, and forms a tumor within the bones of the jaws. And then another common one is a dentigerous cyst, which is a cyst that's associated with a tooth that has not erupted yet. So often associated with the crown of the tooth and develops from the follicle of the tooth that is actually forming the tooth. I think sort of often often in the maxillofacial region, a lot of these tumors and cysts are of odontogenic origin. So in saying that, it means that they are being formed by the structures that would usually form tooth. And I think it's also important to realize that a lot of these sort of benign tumors can act very aggressively. So it's not only the malignant tumors that act aggressively within the facial region, particularly in the pediatric population, but sort of a lot of these benign sort of tumors and cysts do act very, very aggressively. And these would include things like desmoplastic fibromas, odontogenic keratocysts that can be very aggressive. I think sort of also to bear in mind is that often sort of the thought of malignant sort of pathology within the facial region in the pediatric population is sort of underplayed. I think partially because we see a lot of sort of squamous cell carcinoma and oral cancers in the elderly, but I think sort of there most certainly are malignant considerations when there is sort of oral pathology to bear in mind, and those would be things like osteosarcomas, rhabdomyosarcomas, and lymphomas. And I think sort of being involved in MDTs is most certainly useful when dealing with oral and maxillofacial pathology. So oral lesions generally associated with the newborn. Epstein pearls are these white pearls you're seeing on the palate, and are formed are common, and they're generally sort of self-limiting. Bond nodules would be formed from salivary gland tissue on the alveolus, and that's what you're noticing there. There are gingival cysts of the newborn, and this picture is actually sort of a patient that I treated in East London with Prof. Chitness that you're seeing there. And here, surgical excision would be advised. The problem with these is that they often affect feeding, as one can imagine, and sort of it has been described that they can affect the airway. This is a melanotic neuroectodermal tumor of infancy, and these tumors need to be excised. They can be quite aggressive and most certainly do reoccur. So just be aware of those. Lesions occurring in children and adolescents. Eruption cysts are cysts sort of associated with the teeth erupting through the attached mucosa in the oral cavity. And often if sort of they fill with blood, they can form a hematoma and give the sort of blue hue appearance that you're seeing here. Mucoceles are very common and generally are associated with sort of trauma to a lot of the sort of minor salivary glands within the mouth and maybe sort of the tongue or the lip. Ranulas I'll come back to. Squamous papillomas are generally sort of associated with human papillomavirus and can sort of either be sort of individualized sort of lesions like this or sort of affect large portions of the mouth in something like Heck's disease. And then sort of localized juvenile spongiotic gingival hyperplasia would present like this. And often this is associated or found in young ladies, sort of as they're sort of moving into puberty, who are mouth breathers or have sort of things in the mouth that can sort of give irritation to the gums. This is a ranula, and I mentioned this because we see this very commonly with this balloon-like sort of appearance within the floor of the mouth. And there are a number of ways of sort of treating it. Some people sort of advocate for aspiration and see if it reoccurs. There can be sort of marsupialization of these conditions. But generally, the way we sort of approaching them now is to act. They can also sort of plunge through the musculature of the floor of the mouth, and by removing this gland, you don't actually have to do anything further for it. Other pathologies, this is like I mentioned earlier, this is an aggressive pathology. This is a desmoplastic fibroma. It's a benign lesion, but you can see it's sort of grown rapidly and deformed this little girl who actually presented to us from the Eastern Cape. And if you look at those MRI images, you can see how it's involved both the bone and the soft tissues and led to quite significant sort of destruction of the bone. This is just sort of an intra operative picture, and you can see how large this lesion was. And then sort of coming to sort of the MDT portion of this is that often sort of the reconstructive options within the pediatric population are quite complex. And in this particular case, we've decided to do a fibula free flap. So we've got the plastic surgeon, microvascular surgeon involved, who has sort of we actually reconstructing the mandible and the soft tissue defects. With a skin island from the. This is her panorex post-operatively, so you can sort of see how we've sort of reformed the mandible. Unfortunately, she sort of developed a pneumonia and sort of spent quite a lot of time in ICU and sort of developed a pressure necrosis of her ear and behind over the mastoid. And then because we thinned out the flap we made so much, we actually sort of got necrosis. But she did well in the long term, and that's her following that. Again, sort of something just to some warning signs, and this is a case just to sort of highlight sort of things that we should look out for. This is a young lady who presented to us. She was 12 years of age with this lesion in the mouth that she said had grown to this extent within the last sort of 10 days. And if you have a look at that lesion, you can most certainly see that there is ulceration of the lesion. So the top teeth are traumatizing the lesion. It doesn't look like she's got too much sort of swelling from extra-orally. But if you have a look at this panorex, And I apologize, not a particularly good panoramics, but if you have a look at this, you can actually see how there's been significant bony destruction of that left mandible with these mobile and sort of teeth that are sort of almost look like they're floating. So floating teeth, and the rest is so floating teeth, sort of which bled easily. They exfoliated sort of spontaneously, and this ended up being a osteosarcoma. And she was sort of taken, and we did a resection for her. She underwent. Um, she's completed now her chemotherapy, and she's actually sort of this is her post surgically, and we're actually now looking at reconstructing her. At the time of surgery, we didn't put any bone um, or any reconstructions that we're now going to sort of use to fill that defect. Just briefly, with regards to pediatric maxillofacial trauma, I think the ATLS principles are always important. I think airway management considerations in facial trauma would always include sort of bleeding of the mouth, which can lead to aspiration, can lead to clots in the airway. I think also sort of foreign bodies, so sort of loose and fragments of tooth within the airway would definitely be things that you would need to consider. They're often associated injuries to the brain and to the C-spine. And obviously sort of diagnosing things and particularly sort of maxillofacial trauma and fractures in children is quite difficult, because not only are they difficult to examine and often sort of quite operative sort of in that sort of initial period following trauma, but also sort of they have a different anatomy where their growth plates that can often be sort of mistaken for fractures. And there are sort of common fracture types that are more commonly seen within the pediatric population. So, for instance, in the mandible, often sort of fractures of the mandibular condylar segment involve the condylar head or the intracapsular joint space, just because sort of the pediatric mandible is a very short condylar neck. So a lot of the sort of often sort of leads to burst fractures within the condyle. Also, sort of because of the fact that the bone is sort of a lot more elastic, there can be sort of more green stick fractures of sort of the body and the parasymphysis. And then sort of with regards to the zygoma and orbit, often because the periorbital sort of sinuses aren't developed in very young children, the fracture patterns are often quite different to sort of the adult population. I think also with regards to pediatric trauma, always sort of considering non-accidental injuries is important. Just sort of which concerns following trauma to the face, I think sort of this white eye phenomenon. So if you're having a look at this picture, this young man is actually looking up, and if you have a look at his right eye is not moving up. And often what happens is in the pediatric population, because the bone is so elastic, in a blowout fracture, so the fracture of the floor of the orbit, the fracture sort of is quite elastic, so it actually bounces back and entraps either sort of the inferior rectus or orbital content, and actually prevents the eye from looking up. And this can lead to ocular cardiac reflex, so they can often become nauseous, they can have a bradycardia. And the concern is that if it's not addressed early, those tissues become necrotic and fibrosed, and that eye movements may be affected in the long term. As I sort of also mentioned, sort of growth can be affected by trauma. So often sort of patients who have undergone sort of any sort of trauma of the maxillofacial region need to be followed up in the long term just to see how they grow. And then sort of with regards to joints, often they can lead to bony ankylosis. So because there's at the time of trauma, there's bleeding into the joint space, a hemarthrosis develops into a bony ankylosis. So bone forms, and then the joints no longer function, and sort of this can in the long term prevent mouth opening. We have mentioned briefly sort of the differences within sort of adult and pediatric bone. And I think sort of the treatment options in children and the complications associated with treating would include sort of affecting growth, but also we don't want to place sort of hardware like we would in adult populations of titanium and plates and screws, because sort of they can hamper growth. So if you have a look here, this is a young lady we've recently treated who presented to us following traumas as a child. And if you have a look at that sort of right condyle, you'll notice that that is sort of a bony ankylosis. So she's unable to open her mouth. And because of she's unable to open her mouth, she started developing asymmetrical facial growth of both her maxilla and her mandible. So when she presented to us, we actually sort of, and this is quite controversial, we ended up sort of doing sort of releasing this sort of bony ankylosing. We ended up placing sort of a joint replacement for her. And the thought behind this was is that hopefully by sort of doing this, we would sort of encourage her normal growth of her maxilla and her contralateral um, uh, joint. This is a young man who's involved in a motor vehicle accident. If you have a look here, you can see in the maxilla there's sort of both Lefour 1 and Lefour 2 fractures, and the mandible there's sort of fractures of that right ramus, as well as that left condyle. And if you have a look here, this is intraoperatively. Once those fractures are reduced, and I don't know if you can actually sort of notice, but what we've used here is a resorbable plate or resorbable plates, a number of them, um, to to um, to reduce the fractures. And the reason for this is that these plates sort of would stay in position for between 6 months and a year, and then sort of resorb down into water and carbon dioxide, and as such, hopefully will not affect growth. So that's the thought behind it. You can see as a better, you can actually see the middle better in sort of the mandible. Also of interest here is you can see sort of the submandibular gland, and often sort of with facial trauma, we want to try and use the teeth as a functional model as to where we want to go. So here we've used the submental pull through. So it's an oral intubation with an armored tube that at the time of surgery, we actually we create a tunnel through the floor of mouth and we pull the tube through that to allow us to put the teeth together and close the mouth while we're operating. Again, sort of just mentioning sort of we often sort of use the teeth as a guide to the functional sort of to restore function to the occlusion. So we wire them intraoperatively, and often sort of post-operatively would use sort of the elastics and wires to keep them in the right position. So again, you can see here post-operatively this child has got a good occlusion. I'm going to move very quickly through this. Sort of congenital conditions, things like cleft lip and palate. There's often a repair timeline, and I think all too often these kids are sort of have their lips repaired, they have their palates repaired, and then they're sort of forgotten. And I think there most certainly sort of is. It's good to remember that sort of after the cleft and the cleft lip and palate are repaired, often at the sort of the age of about 8 years of age, they actually do need bone grafting of their alveolus, which is the tooth-bearing segment of the maxilla, to allow their permanent teeth to erupt into the right position and to start orthodontic treatment. Okay, and I think that's sort of important. And then inevitably, because of the fact that they end up with quite retrognathic maxillas, they do need orthognathic surgery in the future, where we actually move the maxilla forward to try and improve their sort of aesthetic appearance. There are things like Pierre-Robin sequence, Treacher-Collins, and hemifacial microsomia, and obviously sort of the role of maxillofacial surgeons here is sort of in the multidisciplinary care. So this young man on the lower right-hand side, Shane, he's got a number of Tessier clefts, and he's currently with us. The plan for him is to actually distract that premaxilla and nasal complex down, and which would also help in sort of with the cleft lip repair. This is a young lady with hemifacial microsomia, and you can sort of see all the sort of phenotypical associations with that. You can see she's wearing a bone anchored hearing aid. She's got an underdeveloped left ear, and obviously quite significant sort of bony and soft tissue defect on that left hand side and joint. The TMJ is also involved, and the reason I put her in here is that I think all too often we forget about the psychosocial aspects of these conditions. And this poor young lady is sort of having quite a tough time at school, and the hope is that we would distract her and maybe fat graft her to try and sort of stop the teasing that she's undergoing. This is just sort of a patient with Apert syndrome, and she presented to us. You can see she's already had a syndactyly repair. She presented us with significant proptosis, and with the inability to close her eyes. So the concern was that she was developing corneal scarring. So this was her CT scan prior to seeing us, and you can see she's actually had a cranial vault remodeling. She's probably she had a frontal orbital advancement, but she still had quite a significantly retrognathic maxilla and very short shallow orbits. So we actually did a Lefour 3 osteotomy for her and placed distractors. And with that, we sort of advanced and grew bone, sort of not only of the orbits, but of sort of the maxilla to improve her appearance. And this is her sort of in her consolidation phase with the distractor in place. Just very briefly, I realize I'm sort of overstaying my welcome a bit, but just with regards to functional and orthognathic issues, I think sort of one of the things that often we sort of neglect to mention to patients is if we're noticing sort of jaw growth abnormalities, so either a very prognathic or underdeveloped maxilla or a prognathic or overdeveloped mandible or the other way around, these can lead to quite significant sort of feeding and speech issues. And I think obviously sort of associated with that would be aesthetics. But currently there's a lot being said about sleep apnea and these craniofacial sort of abnormalities. And I think sort of that's something we most certainly need to bear in mind, and it's something we should be looking out for. So this is actually quite an old case. This is a guy who I treated as when I was a registrar, and he had been in the system for a long time. He had been a child who had been noted to have facial asymmetry. He had gone through orthodontic treatment, so you can see he's got braces on here. You can see he's got significant facial asymmetry. He's got an underdeveloped maxilla. And what we did is he completed his orthodontic treatment. This was the surgical plan with regards to moving his mandible back, doing what we call a genioplasty and moving his jaw, his chin slightly forward, and then rotating his maxilla both forward and down. So that's what you're noticing in the surgical planning. Nowadays, the surgical planning would be done sort of virtually, and 3D models would be printed, and we would plan our surgery that way. But this is his post-operative result, and you can see how his facial asymmetry is improved, how his dental function has improved. You can see how his teeth sort of fit nicely together in that lower picture. And again, just sort of showing what can be done for these patients. So in conclusion, just sort of initially, sort of we hope that the objective of this talk would be to highlight the relevance of maxillofacial and oral surgery in pediatric surgical practice, for us all to have a better understanding of maxillofacial and oral surgical pathology and scope, and then the importance of working in interdisciplinary teams. And then sort of moving on to the final thought, I think sort of recognizing clinical signs and asymmetry, delayed eruption of teeth and non-resolved swellings, and for that to be a sort of a warning to us. Know when to biopsy and to refer timeously to the relevant disciplines. I think sort of collaboration in management of many of these maxillofacial pathologies results in obviously improved patient outcomes. And I think sort of another sort of final thought would be to avoid underestimating dental issues. So the key takeaways would be to recognize maxillofacial related conditions early, to maintain close links with maxillofacial teams, and then to integrate maxillofacial and oral surgery into MDTs for complex cases. Perfect. And any questions? And I'm happy for anyone to ask or to contact me, and those are my contact details that you're seeing over there.
Yes, thank you, Martin. That was a really nice overview of maxillofacial pathologies, which we need to be aware of. And luckily we have sessional maxillofacial surgeon back here. And the most common pathologies I think we deal with are tongue ties, ranulas. We do see from time to time, and they do trouble us. So what is your opinion about ranula? Should marsupialization, is it adequate, or should somebody try to really resect, especially if they are large and
Yeah.
involving the entire floor of the mouth, not causing respiratory distress as yet, but could cause respiratory distress and problems. So what is your advice on that?
Robert, it's a good question because I think, I think these decisions probably need to be made with the patient. I think sort of one size probably doesn't fit all here. My sort of current experiences is that sort of a lot of sort of people like to aspirate a ranula, and inevitably, in my experience, they reoccur. So aspiration helps sort of in the interim, but in the long term, they reoccur. There is a lower incidence of recurrence with marsupialization. And often if you sort of marsupialize and you put a silicone drain in and you try and secure it, for as long as possible into the floor of mouth. Often that sort of can help. But I've sort of changed my practice, and this is quite strange for me because I'm generally quite a conservative surgeon, but I do sort of now sort of generally remove the gland. So I discuss it with the patient and we make that decision together, but I do probably more often than not remove the sublingual gland just to prevent the recurrence. Um, Interestingly, if there's they also have been described of using sclerosing agents within these lesions. I've got no experience in that. Um, but what I would also say is that in removing the gland, if there is a plunging ranula where it sort of moves through the musculature of the floor of the mouth, you treat the condition anyway by removing the gland.
Yes, thank you. That answers
I
my
think I think
question,
this is
Martin. Yes.
yeah.
I don't
I,
see
I
any
think
question. Yes, sorry, go ahead.
yeah. No, sorry, Prof. I think it is important, and I think you mentioned you said it, sort of. I think risk versus benefit of removing the gland. It also needs to be borne in mind, and I think often sort of damaging that submandibular duct has been associated with removing the sublingual gland. So being aware of that submandibular duct, and the other structure that's obviously sort of quite important is obviously the lingual nerve, and it does run very closely to the submandibular, well, mostly to the duct and to the sublingual gland. So that's if you are going to remove the sublingual gland, I'd most certainly say cannulate the duct and most certainly try and visualize the lingual nerve early before sort of removing the gland.
Yes, thank you. I think you have said it multiple times that it is multidisciplinary therapy. We need to work, all of us work together and use the expertise, especially of the maxillofacial surgeons. I don't see any questions in the chat box. Anyone wants to ask any question to Dr. Dr. Bruce Wulami is here from Zambia. How often do you encounter tongue
Okay.
ties that need attention? Interesting question, Martin.
It's a good question, and um, in I, I'm going to sort of say that I generally I think tongue ties are being treated way too often. That's my personal sort of feeling on things. I think the literature would show that there's been an exponential increase in the number of tongue tie releases. My general practice is, particularly within sort of the first month of life, is to see how the child is growing. And we've mentioned sort of multidisciplinary teams, but generally what I would do is I'd get a lactation consultant involved early with these kids. If there is a struggle to latch or there is a struggle with feeding, get a lactation consultant in early. I'd watch their weight and see how it if it's improving. Um, but I think we're probably doing way too many tongue tie releases, and personally, I sort of am doing less and less. If I'm honest, I'm most certainly following these patients up. I'm also having quite significant discussions with the parents, and sort of I think sort of because there's quite a big push on social media to address tongue ties. I think parents are becoming better educated and looking out for tongue ties. And I think often a tongue tie is being made the scapegoat for difficulty in breastfeeding. And I think it's also important to realize that breastfeeding is hard, and it often doesn't, we think it's sort of going to come very naturally, but it often sort of takes a little bit of time with a lactation consultant and to get it right. And I can attest to this out of my own experience. Both my wife and I are medically trained, and she most certainly struggled with breastfeeding. And the help of a lactation consultant was great. So initially there was some concern about in fact, for him it was a lip tie, but there was no need to release that. I do think that another thing, just important thing to bear in mind with regards to tongue ties is that um, tongue ties have been associated with articulation problems, but delayed vocalization, there's no reason for there to be delayed vocalization. So if there's delayed vocalization, it's most certainly got nothing to do with the tongue tie. So that's also just saying just to bear in mind.
Martin, are tongue ties really significant tongue ties? Are they associated with difficulty in speech or lisping or things like that?
The interesting thing, Prof, is that a lot of literature sort of would show that even if you aren't so letters like or sounds like the th and l, where they are the biggest tongue movements. If there is a tongue tie, children can often sort of accommodate, and instead of lifting their tongue, they actually drop the tip of their tongue and are still able to pronounce an L and a TH. Um, in saying that, I'm not advocating that you don't do a tongue tie release for these kids. And I think the importance here is actually sort of getting the speech therapists involved. So again, the multidisciplinary thing is important. Getting a speech therapist to evaluate the child and to give her inputs would be advisable if there are articulation problems.
I fully agree with you, Martin. For a couple of years, we had a lactation consultant here, and that was extremely helpful. And she only picked up tongue ties
Yeah.
if there was real feeding difficulty, child was not gaining weight, and then I had no hesitation in releasing those tongue ties. And obviously, speech therapists are quite important in decision about release of tongue tie a bit later in the childhood. Yeah. So that was good.
Yeah.
Anybody else wants to post a question in the chat or just unmute and ask a question before we wrap up? Okay, so that's great, Martin. Thank you. It was really nice meeting you virtually. We would like you to come and at least have a holiday here so that we can meet you and your family. And we wish you well for all what you're doing in Cape Town. If you can stop sharing, I just want to share the last slide about the Pan-African Pediatric Surgical Association meeting in Abidjan, and then we will stop.
Perfect. Thank you very much, Prof, and yeah, thank you for the invitation. It really is an honor.
No, it was really great having you, and thank you again, Martin, and so the biennial meeting of the Pan African Pediatric Surgical Association (PAPSA) is around the corner. It is going to happen. The actual meeting will take place on in Côte d'Ivoire, in Abidjan in Côte d'Ivoire. The actual meeting is 29th and 30th of May. But on the 27th and the 28th, there are pre-conference courses or workshops which are happening. So anybody, I'm sure there are many colleagues, including Dr. Bulami from Zambia, anybody from Africa who is still interested in registering, the registration is open, and we would like to welcome and see you there. So with that, we conclude today's talk, and I thank Martin again. And it is really something which we need to know, and we need to involve the experts as soon as possible. Thank you all. We probably won't have a Zoom meeting in June. The next Zoom meeting will be in July about reconstruction in burn injury patients. Thank you all. Good night.